to share my work. I come from Chongqing Medical University. The title of the presentation is Prevalence, Risk Factors and Outcomes of Subsyndrome Delirium in Older Adults in Hospital or Long-Term Care Settings, a Systematic Review and Meta-Analysis. There are 6 main aspects to this topic, starting from background. Then I will introduce our aims and methods, and next I will show the results for our works. Finally, I will conclude this study. Firstly, I will come to the background. Delirium is an acute disorder of consciousness and altered cognitive function, and usually lasts for several hours or days, with repeated fluctuations during episodes. Acute impairment of attention and cognitive function, altered level of consciousness, orientation disorder, and perceptual impairments and fluctuation in condition. The prevalence of delirium in the older population ranges from 11% to 51%. Delirium has been linked to a variety of negative consequences and increased mortality, such as complications increase, intended hospital stays, increased hospitalization costs, and cognitive decline after 1 year, increased readmission rates, reduced long-term survival. And what is subsyndrome delirium? In medical practice, it's common for older adults to present with one or more symptoms without meeting all the delirium criteria. The occurrence of such symptoms has been labeled subsyndrome delirium. How does subsyndrome delirium relate to delirium so far? Quantitative rather than qualitative. Similar risk factors and associated with several adverse outcomes like delirium. As pharmacological treatment of subsyndrome delirium is still inconclusive. Clinical recommendations are based on non-pharmacological treatment options. Therefore, it's crucial that healthcare professionals promote, recognize, intervene, and prevent the progression to delirium in patients with subsyndrome delirium. Therefore, the aims of the present study is to better understand the current situation, a systematic review of the study related to the prevalence, risk factors, and outcomes of subsyndrome in older adults in hospital or long-term care settings were performed to analyze the overall level of subsyndrome delirium and to identify related risk factors in this population. Okay, now I will introduce the methods. We searched 10 databases. The search time was limited to August 8, 2021, and the search terms were subsyndrome delirium and subclinical delirium. We included the studies that met the following criteria: observational or quasi-experimental study designs. The patient's mean age was 16 years or older. The diagnostic criteria for subsyndrome delirium were acceptable. Patients who come from a hospital or long-term care settings. Information on one or more of the prevalence, risk factors, and all clinical outcomes of subsyndrome delirium was included. Secondary analysis of experimental or quasi-experimental studies were eligible as long as other inclusion criteria were met. Studies with full test available, and inclusion were only had dates on or attributed on delirium. Conference abstracts, editorials, investigations of delirium tremor, cognitive level questionnaires. The following key elements were provided in that instruction. First, the author's last name, publication date, study design, literature source, number of subjects, mean age, gender distribution, prevalence of subsyndrome delirium, risk of survival and outcomes, measurement frequency, and diagnosis standards. The Newcastle Ottawa scale was designed to assess the quality of cohort and case control studies, and the Agency of Healthcare Research and Quality recommendation checklists were used to evaluate the quality of cross-sectional studies and other descriptive studies. Pooled statistical analysis was conducted using the Stata software. A value of 75 or more indicating considerable heterogeneity, and 25% or less indicating low, and between 25 and 75 indicating moderate. And our primary dates were subjected to sensitivity analysis. Publication bias using two methods, the back test and the final plot. I will show the results. The original database comprised 2,426, 2,066 of which were included based on title, abstract reviews, and full test reviews, leaving 22 studies available for the quantitative analysis, and 19 articles available for the quantitative meta-analysis. Main characteristic of included studies. The mean age of the included participants ranged from 17.17 to 18.7 years, and the number of the participants in each study varied widely. The prevalence of the subsyndrome delirium in this study, participants ranged from 6% to 75.6%. We conduct a sensitivity analysis to analyze the stability of the studies. After removing individual studies, the prevalence of subsyndrome delirium in the older adults remained stable. The scatter distribution in the final plot were uniform and symmetrical, implying that there were no completion bias. The prevalence of subsyndromal delirium in older adults is in Figure 2, which incorporates data from 19 studies. Results show that The overall risk ratio of subsyndrome delirium in these patients was 36.4%. Due to the high heterogeneity between the studies, a layout of mean age, gender, region, study design, what type, and assessment tool were created. Results of the subgroup analysis show that the prevalence of subsyndrome delirium in patients with a mean age of 17 to 18 years were lower than in patients older than 18 years. Males have a higher score compared to females. In the different regions, American, Europe, Asia, the prevalence rates were 42.4%, 11.7%, 32.4% respectively. And the majority of studies utilized the CAM, and this study reported great prevalence compared to CAM and DSM combination studies. 12 studies reported information about the risk factors for subsyndrome delirium. In the quantitative analysis, 5 risk factors with 2 or more matching diagnostic criteria. Of these, 4 statistically significant risk factors were advanced age, lower hemoglobin, and dementia, and low ADL. For the AMSE results, there were no significance in our study. That maybe because there was a significant heterogeneity among these studies. Nine studies reported information about outcomes of subsyndrome delirium, associated cognitive and functional decline, and increased length of hospital stay, increased rates of admission to long-term care institutions, a higher mortality rates. Patients with subsyndrome delirium were more likely to develop delirium than those results, and my results in more severe emotional and behavioral problem after discharge. The severity of the patient's clinical outcomes of subsyndrome delirium appeared to range between delirium and those status of being free of delirium. Thus, our results might provide useful information for clinical practitioners. As subsyndromal delirium has a high incidence in older adults, it's associated with many risk factors and poor outcomes. Therefore, clinical practitioners should improve the identification and assessment of subsyndromal delirium. Currently, nurses' awareness of subsyndrome delirium is low. Therefore, nurses should be systematically trained on subsyndromal delirium related knowledge, including epidemiological assessment methods, prevention, and care measures. Managers should enhance the subsyndrome delirium specific training of nurses to provide them with new and updated knowledge on subsyndrome delirium in a timely manner, and to improve their ability to recognize subsyndrome delirium as an insidious phenomenon. For researchers, it's essential to explore subsyndromal delirium assessment tools that are applicable to older adults because there was still no target diagnostic carrier for subsyndrome delirium, and its assessment still rely on the tools used to diagnose delirium. To validate the effectiveness of non-pharmacological interventions for delirium, like ABCDE clustering strategy, early activity, daily arousal combined with music therapy, the cognitive training, longitudinal study can be conducted in the future to verify the relationship between subsyndromal delirium and delirium. In addition, to prevent the significant heterogeneity across studies and to reduce publication bias, it's recommended that future studies set uniform criteria to facilitate the clinical monitoring of the occurrence of subsyndrome delirium and to improve comparability between studies. There are several potential limitations to this study. The included articles were all published studies that are public accessible, and no additional information were requested from the authors. The diagnostic tools used and the frequency and the duration of patients' observation different from study to study, results in the inclusion heterogeneous findings, some of which should not be eliminated even with subgroup analysis. In addition, we included risk factors using an unadjusted univariate analysis, which might have introduced some bias. Finally, I will conclude this work. Our study systematically evaluated the prevalence, risk factors, and clinical outcomes of subsyndromal delirium in older adults in hospital or long-term care settings. It was found that subsyndrome delirium has a high prevalence and it may be closely associated with a variety of known risk factors, and that it can be lead to poor outcomes. Due to the small sample size and the low quality of the study, it is recommended that future multicenter studies with large samples will be conducted. That's all of my presentation. If you have any questions, I'd happy to answer them. Thank you for your attention.